Thank you all very much, and I really appreciate everyone's participation in the panels. The feedback that I've received so far is that they've been just fantastic, and it's really been because of the participation of everybody that's attended. And I think what's made this conference effective is that people wanted to participate and wanted to help and contribute to this common dialogue. But it wouldn't have happened had not all of you who came and helped, donated your time and your energy to help us better understand the many issues surrounding this common cause that we all share in common. I want all of you to know that who weren't able to go to another session that you wanted to attend, that we are videotaping each of these breakout sessions, and that we're going to make those available on the website. And in addition to that, with some of your assistance, we're going to kind of triage, in the emergency room parlance, a lot of the best highlights from each of these breakout sessions, such that we can continue this dialogue and make it user-friendly to many of you as you are around the country doing the work that you're doing in this field. My pleasure now is, let me just also thank Bill Emmett for being such a tremendous asset in helping us pull all this together. And I'll acknowledge there's so many people who are instrumental in making this possible. But let me now invite Linda Rosenberg to come to the stage and the rest of the panel that's appearing now, because in introducing Linda, she will introduce our distinguished panelists, all of whom are familiar faces. Come on up, you guys. All of whom are familiar faces in the legacy of advancing mental health in this country. But I had the privilege of kicking it off by handing the microphone to Linda. Now, Linda's organization, the Council of Behavioral Health, is really the organization that typifies this movement of community mental health. That is the mandate of her organization. And not only does she carry that great vision of President Kennedy's kind of prescient policy making, but she herself is a visionary. And she has articulated the value of the ACA in really transforming the system of care available to all of us, no matter what individual community we come from. And that's been her value in communicating the broad interest that we all should have in joining together to articulate what is in our common interest, so that we can be more effective by working together to achieve that common interest, as opposed to all of us chasing down these various rat holes of proposals that get us lost and separated and fragmented, thereby limiting our effectiveness in being able to achieve anything with any degree of success. So I really want to thank Linda for being that kind of political person in this field to help us articulate the message as it needs to get put to members of Congress, my former colleagues, so that we could get some effective action on next steps to take after the implementation of the ACA and mental health parity. So with that, let me turn it over to Linda, and she'll introduce all of our distinguished panelists. Thank you so much,
Patrick.
Linda.
Thank you, Patrick, and thank you for this opportunity. I'm humbled to be here with all of you. Each panel I've had or tried to go from room to hear a bit of each panel, and it's just been so impressive. Each of you have so much to offer, and we're going to make sure that as part of this panel, you will also have time to participate. But let me begin by introducing these incredible panelists. Let me start with Dr. Jeffrey Lieberman. Dr. Lieberman, as many of you know, is president of the American Psychiatric Association, and he's also head of the Department of Psychiatry at Columbia University, a very prestigious role indeed. He's a physician and a scientist who spent over 25 years caring for patients and studying the nature and treatment of mental illness. Dr. David Satcher also needs little introduction. He's director of the Satcher Health Institute at Morehouse School of Medicine, and as the 16th Surgeon General of the United States, Dr. Satcher released the first Surgeon General's report on mental health, along with companion volumes on culture, race, and ethnicity, and a call to action to prevent suicide. It was really groundbreaking and continues to guide many of us. To my immediate right is Pam Hyde, an attorney and an advocate who served as administrator of SAMHSA since 2009, and before that was New Mexico's Cabinet Secretary for Health and Human Services. So we're thrilled to have her with us as well. And of course, Senator Gordon Smith. Senator Smith right now is President and CEO of the National Association of Broadcasters, a very important group to many, many people in this room and many of the stakeholders in the mental health and substance use disorder communities. Before that, as most of you know, he was a two-term senator from the state of Oregon. He is why we have the Garrett Lee Smith Act, why we have suicide prevention and education on our radar screen, and hopefully he's going to talk a little bit about where we've come and where we need to go. And last but not least is Madeline Will, co-founder and chief policy officer of the Collaboration to Promote Self-Determination. Ms. Will is the mother of a son with Down syndrome, and she's been an advocate as well as a government official for 3 decades, and certainly an activist. So we have an interesting panel, right? We have government here, we have psychiatry, we have primary care, we have the media and politics, and we have advocacy. So I'd like to begin with a broad question, and then I have really some specific areas I'm curious about in terms of each of your work and each of your roles, both now and in the past. But the broad question really is, we have a great opportunity, I think we know, as a result of parity. We know the final rule is coming, but even before we see that rule, really we know we now have equality. But that's just a baseline, right? We also have the ACA, we have the Affordable Care Act, and all that that means to Americans generally. We know Medicaid will eventually be expanded in every state, if not immediately, and we know certainly that the website for registering for the health exchange will eventually be up and running. So taking that as our background, I was wondering if we could start with you, Dr. Satcher, and you can kind of look back from your very seminal report to these 2 other very important events, parity and the ACA. Where do you think, what's the progress we've made, what do we still need to do, and where we need to come together to accomplish your remaining goals?
Yeah, well, I think parity of access to mental health services was a major recommendation of our report. And we had even shown, with the leadership of Howard Goldman and people like Tom Borneman, that was in fact cost effective, that we could actually save money by making sure that people had timely access to mental health services. So we've come a long ways, and I think when President Bush signed the Parity Act, and then, with including substance abuse, it was a seminal day for me and for a lot of the rest of us. And I think the Affordable Care Act and assuring that people would have access to mental health services as a requirement, as an essential service, but also assuring that people could not be denied insurance generally because of a history of mental illness. So we've come a long ways, I think, in terms of what we tried to recommend, not just in that report, because as you pointed out, we were concerned about disparities in the burden of mental illness. Patrick last night talked about the burden of mental illness, and I think what we saw were major disparities because some people had such difficulty accessing mental health care. So I think with the integration of mental health and primary care, we continue to make progress, I think, both in reducing stigma, because now we're not separating access to mental health services from access to other services, but also I think we're making progress in terms of of access. People can get mental health care without being referred to somewhere else with a referral that they usually will not keep. So I'm very pleased about that, and I think it speaks well for the future. We need leadership. I want to say that. The name of my institute is the Health Leadership Institute, and one of the things that President Kennedy said, or would have said in Dallas that I remember, was that leadership is about learning. And when leaders stop learning, they stop leading. And that's part of the motto of our Health Leadership Institute, is that at the Satcher Health Leadership Institute, everybody teaches and everybody learns. And it's really helped us in working with the community that we serve.
Thank you. I want to turn to Pam, who I know has sat here since yesterday before the gala, that wonderful event, and has been thinking not only of what we've accomplished and the kind of celebration we're having, but what we still have left to do. I know she's been reading some of the original writing of President Kennedy, and I was wondering if you'd share with us some of your thoughts.
Sure, thank you, Linda, and thank you for facilitating this. And I want to thank Patrick Kennedy. I don't see him right at the moment, but he's out there somewhere. And Patrick, this has just been, over here, there you go. It's been not only your leadership on all the congressional issues, but obviously in this event and the forum, this is a major kickoff to, I think, what's going to be a really great opportunity to talk together about how to go forward. So thank you. I did go back and read President Kennedy's comments to Congress, and I listened today. Obviously, I didn't get to go to all the workshops, but I listened to some of the things that either he said in his remarks to Congress that we didn't touch on today, or at least I didn't hear, or things that he didn't talk about because they just weren't on the radar, like health information technology. That was mentioned a little bit. Nowhere in there did the president, obviously at that point, 50 years ago, talk about what kind of a change that was going to make in our lives. There's an amazing set of information in the words he used about costs and financing. He talks about that mental health services should be financed in the same way as other medical and hospital costs. That seems so straightforward. Was obviously a precursor of parity. He talked about the major causative effects and role for adverse social, economic, and cultural factors. I mean, clearly had his head wrapped around disparities. I haven't heard too much about that. Maybe some of the other panels did that. He also talked about the idea of cure and function being restored. So it's almost like this recovery construct, but a concept of cure that, frankly, in many ways we don't really have at this point. He also talked about there was environmental issues that, if I can find it here, harsh environmental conditions, which often are associated with mental retardation and mental illness. Clearly, trauma, social determinants, those issues. So I was really struck by the language he used and how much we are trying to deal with those issues, but frankly, I don't think we've gotten all the way there. The other thing I was very struck with in his words was all the discussion about workforce. He put proposals together and put proposals in this message to Congress about workforce. For some of you, you will be amused. He said there should be one psychiatrist for 360 patients. Would that we were so lucky to have only 360 patients per psychiatrist. And he also talked about paraprofessionals. He talked about aides, psychiatric aides, and auxiliary personnel. I mean, these are very cutting-edge issues today that he was talking about 50 years ago. I didn't hear a whole lot about workforce here, and I am constantly struck. We've been doing a lot of thinking about it at SAMHSA, working with HRSA, is we can have all the equity we want, and we can have all the ACA we want, and if people can't get into care because there's nobody to provide it, then we've got a major, major issue in front of us. So I think that is a big one.
You've got applause. You know, Pam, I hope we get back to that, and I hope we tie two things together that you mentioned, technology and workforce. Because I think if you look at any other industry, you will see technology taking the place or at least extending the workforce. And I think that's a piece of what we have to do, because I think we'll never have enough people, although I think you just gave the APA a goal in terms of the number of psychiatrists they need to recruit and enroll.
Yeah, yeah.
But I want to go to workforce really with Madeline for a minute. So I sat in on, I tried to go from session to session, as I said, and one of the things that I was struck by really everybody was talking about, from the original panel with Steve Edelman to Bob Borstein to Bob Drake, was really about the role of work in our lives and how that helps define us as productive and successful. And yet I was also struck, and whenever I think about it, how little we've moved the needle in terms of work and people with disabilities, very specifically intellectual disabilities and mental illnesses and addictions. So another thing that was said in one of the rooms, and I'd like you to comment on this, is that there is going to be new enforcement of Section 503 of the Rehabilitation Act, which means that 7% of all federal contracts must have people with disabilities as their employees, which in the first year could mean 600,000 jobs. I'd like you to talk a little bit about how we prepare to fill those jobs with people with intellectual disabilities and mental illnesses, particularly because many of those jobs will be technical in nature. I think it goes back to the role of technology in really transforming our world.
Okay. If you don't mind, I'd like to just put this in context. I am the governmental affairs person for a coalition of 18 organizations that came together in 2008, and our goal is, among others, to break the link between poverty and disability. For 10 consecutive years, people with disabilities have been the poorest minority in our country. And as we, our group focused on policy issues, we decided that we would take on the task of employment and of coming up with actually 4 pieces of legislation to eliminate barriers to employment, which include asset limitations and income limitations, and many other disincentives to work. One of our pieces of legislation focuses on the transition from school to work and what needs to be done there to enhance preparation of young people. And we know what the research says, but it's not translated into policy yet. For one thing, we have to begin speaking to parents about work at a very early age, because they themselves often have low expectations, as do teachers and others in the environment. We need to begin focusing on college and career-ready preparation at an early age, at 14, certainly no later than 16. We have a need for dual enrollment programs that will allow students in high school to take classes in colleges, community colleges, and other college programs. We have a need for increasing post-secondary education programs for students with intellectual and developmental disabilities. In terms of curriculum, yes, we need to focus on the development of technology. One of the important correlates we see between high school training and jobs is computer literacy. So that is something that we need to make sure that our youngsters have in their, if they're in special education and not in special education, in their curriculum. And we need to focus on what we call universal design for learning, which is adapting the curriculum, individualizing it so that you have very creative ways of presenting information to the student, multiple ways of allowing the student to give back information, and multiple ways of assessing their learning. The most significant correlate, however, between employment, high school preparation, and employment is having paid or meaningful work experience in high school. It is absolutely essential that we embed in transition programs for students paid work experiences, meaningful internships, and these are things that we have yet to focus on.
So someone else on our panel who's focused on youth to a great extent, of course, is Senator Smith in your work. But your work has gone beyond youth to look at the whole area of suicide prevention, and you're heading up the Action Alliance. Wonder if you can reflect a bit on how we're doing, where we're making progress, but where we're really not moving the needle, and some ideas that have come out of your work about what we need to tackle.
Well, thank you. It's a privilege to be here, and that's doubly so because Patrick Kennedy asked me to be here. If I may, with a point of privilege, Patrick said some nice things about me last night at the gala. I want you to know that the Garrett Lee Smith Memorial Act, I didn't name it that, my colleagues named it after my son, that would not have become law but for Patrick Kennedy and his having the courage in the House of Representatives when I called him and said, some in my party are trying to put a poison pill in this bill so that the Democrats will vote against it. And we worked out a strategy so that the Democrats would hold their courage and they would vote for it, and we would fix the poison pill immediately thereafter. He was a champion, and I simply say to Patrick that when I think of his uncle, President Kennedy, who was my cousin Stuart Udall was his Secretary of the Interior. When I think of President Kennedy's vision, which I heard articulated as a young boy, I was physically at his inauguration. When I think of his visionary leadership of this country, I simply want to say publicly that that vision's in good hands with Patrick Kennedy. Let me make this further point as it relates to any of you who have a role in advocacy for mental health, and I suspect that that's all of you. Please understand that mental health does not register Republican or Democrat. It registers as human. And some of the champions that I think of that I worked with, first on Garrett Lee Smith and then parity, they included Republicans like Pete Domenici and George W. Bush. And some in my party tend to be real focused on opposition to government involvement in things, and I've always thought of that as root canal politics. The government is a tool. And if you want to appeal to Republicans, make it very clear to them if they're interested in saving money, increasing human capital productivity, keeping our jails less full and our streets safer and our emergency rooms available for emergencies, then they should support, for financial reasons, mental health programs. And so please bear that in mind. This is not a partisan issue, and there's something for Republicans and Democrats to get involved in together and to heal the breach that exists so often in the toxic politics of our day. When it comes to youth advocacy and outreach, that's where my involvement began. I didn't find this issue. This issue found me in the form of a wonderful son who we adopted as an infant. And if I think of him, it is always in these two words. He was a good boy, but he had a terrible mental affliction, which in all of the checkups of his youth, for physical, eye, teeth, all of those things, the questions were never asked, the right questions as to his mind. And as his parents, we did not understand the signs of depression sufficiently, and we were not in a position, therefore, to help soon enough. And so there are so many areas, so many threads need to be pulled together to create a safety net that is sufficient for the young people in this country. And it really begins with, obviously, educating parents, and the media can have a big role in that. And the producers of entertainment content can make a lot of improvements in that. And they're hungry to know how. But when I think about how do we get this in at the ground floor, Patrick can tell you that all the incentives were wrong. They're all prejudiced against mental health, falsely believing that that adds cost rather than saves costs. So we've got to start at the medical school level. My neighbor in Oregon is an OBGYN physician, and he tells me that his practice is on women's health, but fully half of his practice is psychiatric, and he had one class in it. Now, you have to get that down to the primary care level. There ought to be continuing education requirements to keep a current practice going so that we get closer to everyone who needs help, so that access is there and they don't have to always be referred out, as Dr. Satcher said. There's just so many things that need to be done as it relates to youth. Now, as to broadcasting, one of the things we're doing is trying to teach reporters how to speak about mental health illnesses in a way that is constructive rather than destructive. And also Chris Dodd, another colleague of mine who runs the movies now, to talk about the content.
You all go into the entertainment business,
yeah,
huh?
we've got it cornered. And, but there is so much that can be done. But when Vice President Biden called all of the entertainment associations together after the Sandy Hook shooting, the focus was on what can you do to change content and what can the government do to restrict guns. And in the course of that conversation, it came my turn to speak, and I said to Joe Biden, who is a dear friend of mine, I hope I called him Mr. Vice President, but I probably called him Joe. And I said, Joe, you know there's not a federal judge in the land that's going to allow us to restrict content. And you can't amend the First Amendment. And we all know how difficult it is to pass gun control legislation, but the common thread in all of this is mental health. And if you really want to save human life, given that there's over 300 million guns in the country, let's fix mental health in this country. That led to the broadcasters producing on their own the OK to Talk campaign. The OK to Talk campaign has had hundreds of thousands of responses to the ads that we have put up, approaching $20 million of broadcast inventory. It has had over 30,000 people click the button, I need help. It simply shows the kind of explosive situation we're sitting on if we don't actually reduce the stigma, increase the conversation, say to people, help is accessible and it's effective.
So Senator Smith, it's okay to talk, and I think we know that young people are using social media talking about their disorders very publicly. A young group just sent me a t-shirt called Bipolar Babe. It's very different in this generation, I know. It's quite different than it used to be. We have the ACA, which is going to extend coverage. We have parity, which says you've got to make treatment available. But I think the issue is treatment available, and can people get it, and do we have treatment standards? And I was wondering if for a moment we can turn to Dr. Lieberman to talk a little bit about the treatment aspect, including research to treatment.
It's good to talk to him, because when you tell me it's okay to talk, and that's the name of our program, and then I'm a former U.S. Senator and there's an audience this big, I immediately feel a filibuster coming on.
Oh, don't Ted Cruz us. I hope not. So would you, and we'll get back, obviously, to the issue that you were talking about as well.
Well, I just want to say that listening to Senator Smith talk, it's inspiring, and it makes me emotional, and about hearing, the experiences you've had and the experience you're bringing to your new role, which we, as much as we're doing with regard to research, with healthcare service delivery, with dealing with all of the other infrastructural elements like housing and education, nothing in this age is more important than the media, because the media is the vehicle to communicating and informing people. So it's so good to have somebody like you in this role now.
And they don't know how to talk about it, and they want to learn.
Yeah.
And that's what we're here for.
That's right.
So as we've heard today, we've come a long way with regard to what I consider to be brain disorders or disturbances that affect the parts of the brain that mediate mental function and behavior. But it's manifestly clear that we've got a long, long way to go, a big job, and tremendous challenges. But I don't think, I mean, I'm only as old as I am, but I don't think the stars have ever been aligned in a way that they are now in terms of providing the best opportunity in human history. We have research which has produced traction on the brain and understanding about these illnesses that's never been before, and to which there's tremendous momentum, and the president has just announced a new initiative. And if you really burrow into the initiative, which when it first came out was geared towards basically technological development, and all of my clinical research colleagues rolled their eyes and said, oh my goodness, disease-oriented research, clinical research is going to get shortchanged. It's not going to be new money. It's going to be taken out of the NIH pie. And if you listen to it, it's to build the nanotechnology, the systems that can record from tens, if not hundreds of thousands of cells simultaneously. And why do we need that? We need that in order to understand behavior and mental function, not to understand more specific functions like movement or sensation. It's the things that affect mental illness and behavior. So we're going to benefit. So the momentum scientifically is there. In addition, we have the legislative developments with the Affordable Care Act, the imminent final rule, the symbolic importance of the 50th anniversary of the Community Mental Health Act, and we have greater social awareness about mental illness, even though it still is very stigmatized here in this country than any other place in the world. So we are really in a very good opportunity. The question is can we execute?
And what should we execute?
Well, what I would say is that, and everything in this economy has to be revenue neutral, and it has to have a time frame in terms of deliverables. And the NIH has tremendous capacity to discover new knowledge and provide the next breakthroughs in terms of causes and cures for illness. But in the meantime, there are low-hanging fruit that we can act on that are actionable right now. Although the organizational process, the strategic process, I think is the challenge. So I'll give you 3 examples. One is if you just take this, people talk about mental illness as if it's a monolithic entity. It's not. It's different illnesses that affect populations that are seen and treated in different settings. And the one that really accrues to the greatest gravity and expense is the individuals with what are called the severe and persistent mental illnesses, something you're intimately familiar with, Linda and Pam, the SPMI populations. There are a whole array of treatments that have already gone through the research process. There's evidence there to demonstrate their effectiveness. We know how to administer them in a time-limited, dose-dependent fashion. I'm not talking about drugs, I'm talking about psychosocial services. The panels of these services should be in every healthcare facility that serves this population. Supported employment, case management, efforts to try and secure stable housing. In addition, the idea of providing primary care in a way that's more accessible or co-localized, because these individuals have vastly excessive medical comorbidity. They die, they have lifespans which are 25 years shorter than their non-mentally ill peers. If we have a primary care capability, even if it's a nurse practitioner, it doesn't have to be an internist, or a means of obtaining that readily. A third thing is, what population smokes more than any others? It's the people with SPMI. There's clearly ways to try and address this. If Mayor Bloomberg can stop smoking in New York City, if you can stop smoking in the pubs of Ireland, and the inpatient units in the hospitals, you could stop smoking in this target population. And now with e-cigarettes, we have another means to act on it. A second area, which is what Senator Smith commented on, is the collaborative care, the co-location of mental health care in the primary care settings. And specifically, we're talking about pediatrics, internal medicine or family medicine, and obstetrics and gynecology. If you talk to any pediatrician, any primary care physician, they say 40% of all of my practice is psychiatric, and that's the case. And then the third, and I think this is the one that's the most bold and also maybe the most controversial, is we've adopted public mental health approaches for many conditions. We screen for tuberculosis, we screen for hypertension, we screen for diabetes, we screen for cholesterol. We cannot sit in hospitals, emergency rooms, clinics, offices, for people to come in, having been referred or on their own, saying, I have a problem, I'm not sure what it is, but mentally, emotionally. We need to be more proactive, have a public mental health approach with regard to, we know that apart from the dementias, the majority of mental illnesses are either genetic or involve early developmental experience, and the sweet spot is in the adolescent, young adult period. So there needs to be an engagement in the public school system, in the primary care system, which we mentioned, and also potentially in the workplace and other environments to stem absenteeism and presenteeism. Now, this raises an issue, and then I'll stop, which is a little bit of a complexity. There's going to be pushback, because it's one thing to screen for hypertension, it's another thing to screen for mental illness. People have feelings about this, and there's concerns about this. The other thing is that there's issues pertaining to civil liberties and personal autonomy that sort of have run up against if you identify somebody who clearly is in need. What if Jared Loeffner, what if James Holmes, what if Adam Lanza had been seen in a routine type of setting and had been told, or his family told, there's something we're concerned about, you should do something, but they don't want to do anything. What do you do then? So there are many actionable things that have been done that I think would be revenue neutral, that require just the political and social will to do.
Would any of you like to, oh great. Anybody like to comment on that?
I actually would like to comment on that. One of the things that I think, it's easy when we're in a room of people that we all think like what's being said here. I mean, we're all on a common page about that. The fact is, one of the biggest frustrations I've had as the SAMHSA administrator is from Tucson to Navy Yard and the subsequent events, we are increasingly in the media talking about mental health as a safety issue, not as a public health issue.
Which increases stigma.
which
And
increases
the
all
way a
kinds of.
reporter should end a report is simply to say, this points out why fixing our mental health safety net is so important to our society.
I couldn't agree more, and we've tried to do, in fact, we've got some media guidelines coming. I know we're working with you and some of the folks you work with on these issues, but as long as the public gets scared of people rather than seeing this as a safety, as a public health issue or as a cost-effective healthcare delivery issue, sometimes, I'm trying not to be too negative here, sometimes I feel like we're going back instead of going forward with all the opportunities around research, around kids being willing to talk more, about all kinds of things, and yet the public perception, as I see it, is we're right on the cusp of going backwards. That's true on substance abuse as well. I think people are, if you look at the way the decisions are being made at the state level and other levels, they're cutting substance abuse, or they're cutting prevention programs, or they're saying you have to have criminal-free backgrounds in order to do certain things, which of course has a major disconnect for people with substance abuse issues frequently. So I really worry big time about this, and I worry about it again in the context of the way I thought about this panel is just what had the President Kennedy wanted to do and how far have we come and where do we need to go. He talked about the warm acceptance of the community or something like that, and it's almost the opposite. It's almost like we've come a little bit that way, I think, frankly, in the intellectual disabilities community. I think the families and the advocates have been somewhat better about that, so now when we see the person with a job in the Whole Foods market or wherever we see them, we think that's a good thing. We still walk down the street and we're still scared of people who are behaving oddly on the street. We still don't know what to do about them. We're still suspect, and the data shows that, about people with substance abuse disorders. Even though people will say they do believe people can recover, they're still suspect. So I'm very concerned about this, and I think as a mental health community, to use that term the most broadly, we have got to get at the issue of public perception.
I'm sure everyone here agrees with you. I'd like to get back to, I want to go to Dr. Satcher, but I want to get back to the whole issue of treatment availability, and people being able to navigate where to get help. Because I think in some of those cases and some of those families just didn't know where to go. And the way we have structured our system makes it very hard to embrace families in trouble and to hang in with them when we're not doing a face-to-face visit where you can bill insurance. So I want to go back to that. But
Just
Dr.
one comment
Satcher.
about that, Linda. That is particularly true in the 18 to 19, 17 to 19-year-olds.
Yep.
It's one whole system when you're 17. It's a completely different legal and service delivery system when you're 19. And I think we leave those young people and those families out on their own a lot.
Agreed. Dr. Satcher, your thoughts?
Well, I have quite a few thoughts. So
Give us three.
I was just thinking about the way that we defined mental health in the first Surgeon General's report, which I think does a lot to tie a lot of this together. We said that mental health is the successful performance of mental function such that one can be productive in his or her life, can develop fulfilling relationships with other people, develop and maintain those relationships, starting with families, and then can adapt to change in their lives and environment, and finally deal with adversity. We debated that definition a lot, but when you think about it, it ties all of us together. Whether we're talking about intellectual disabilities or mental disorders, the thing that ties all of us together is the goal of mental health, the fact that people will be able to function and be productive and to have fulfilling relationships. Marion Wright-Elliman and I were at the Washington National Cathedral Sunday talking about youth violence. And on the one end, when we talk about mass killings, we are almost invariably talking about mental illness that was not adequately treated. I won't say was not known, because in the case of Alexis, who did the Navy Yard shooting, he had asked for help. But what about all of these kids out there in the street, in gangs, almost 5,000 killed each year from guns. What about their mental health? What about their inability to have fulfilling relationships with other people? What about the fact that they are living in fear and think that in order to protect themselves, they have to be a member of a gang and they have to be armed to the tilt? So I think we need to focus more on mental health as a goal for the entire society. At our institute, we're dealing with 3 or 4 different populations, and I'll be brief. One, we decided 3 years ago to take over mental health emergencies in Grady Hospital, the largest public hospital in the South. We did this because it was a population that nobody wanted to have anything to do with. And they would often come to the emergency room and just sit and wait for hours for a psychiatrist or somebody to come. So working with the state of Georgia, we decided to take over that population. And we were able to recruit some really outstanding mental health specialists. But what happened over time, of course, is that we were able to sort of transform that population. We were able to dramatically reduce the waiting time. The emergency room appreciated that. We also were able to reduce costs. We were able to demonstrate a 30 to 40% reduction in cost of dealing with that population, in part because what we did with that population was to get them involved in continuity of care at a community. We now work in 10 community health centers in terms of integrated care. But we also work at a homeless shelter. And it's interesting that 60% of the patients there are veterans who've come back to this country needing care. A lot of them are homeless, not because of their financial situation, but because of their mental health situation, and trying to get that population the care they need. And then we work with the population coming out of prison. We have a lot of trouble reintegrating into society. So we have programs in Georgia and in Mississippi. And then, of course, to get even further out there, we work with former NFL players who are suffering dementia and who do some of the same things in terms of their family situation, in terms of suicide, in terms of divorce. And so we have all of these areas where we somehow need to come together and decide that we're going to create an environment where people can be mentally healthy. And David Kessler, when he was director of the FDA, said something about smoking that I always remember, because you know next year is the 50th anniversary of the first ever Surgeon General's report on smoking and health. And President Kennedy, by the way, appointed that Surgeon General, Luther Terry, who released that report. But ever since then, every Surgeon General has released a report on smoking and health. So it's interesting to say, what did we learn from all of these reports? We've learned that smoking is a pediatric disease, and that's what David Kessler called it. And it's amazing how many of the mental health problems we're talking about are really problems of children. And if we got to children earlier and they got access to care, it would make a world of difference in this country. It's a pediatric disease. And there are a lot of other lessons that we could talk about in terms of rising to the occasion, being concerned about the environment, even going to the point with smoking, of course, to restrict smoking in public places. But how can we improve the environment for our children so that they have a mentally healthy environment? So we've got to provide quality care for people who need it. We've also got to promote mental health as a public health.
Dr. Lieberman?
Can I make a comment to follow up
Sure.
on that? You know, we have to promote mental health, and mental health really is a very broad range of issues. Psychiatry is not a primary care specialty. On the other hand, most individuals in the course of their life, just like they periodically need a dermatologist, just like they periodically may need to see a rheumatologist, have issues with respect to their mental functioning. Doesn't mean a psychiatrist needs to treat them. Psychologist, social worker, therapist, their primary care physician, their gynecologist can do it, but they need to have the education to be attentive to it and know what to sort of ask about, and what to do, and when to refer. And this level of awareness and prioritization just doesn't exist, but could if mental health as a goal, not as this dichotomous thing of mental illness and then the rest of us.
Should we think differently, though, about referral? You know, Harvard just announced a project where they're putting clinical staff in their primary care settings, and then they're using psychiatrists really as consultants and supervisors, but using telemedicine. Is the idea that people are going to go someplace else, or should we bring that expertise, as you're talking about, into the health settings, and sometimes using psychiatrists in that way, but using technology? Is APA kind of comfortable with that?
Absolutely. Well, I mean, it's like, is APA comfortable with, you know, the sun rising tomorrow?
Good.
You know, I think we are. We have to be. I mean, I think we do it both ways.
Yeah.
Because the reality is that, look, the country has, the major threat to the country and the responsibility of the government is to protect the citizens, right? So war. After that, it's the economy. What's the biggest threat to our economy? It's healthcare costs, the rising healthcare costs. So clearly now, to bend the curve, the mandate is provide healthcare in the best quality but cost-effective way. And this imperative demands that we use the multidisciplinary team of healthcare providers, from peers to mental health technical aides, to nurses, to social workers, to psychologists, psychiatrists, rehabilitation, in teams in the most effective way in a variety of settings. And we don't have the blueprint mapped out. We're working hard right now to do it, but that's the future.
So you've talked about, and Dr. Satcher has, Madeline has, really the pockets of excellence that exist, where we're doing things state of the art, right, in different parts of the country. But we have a problem around standards, it appears to me. And I was wondering if anyone else has been giving some thought to that, as really our next kind of, certainly for mental health, a mountain to climb, to have some standardization. If I have a certain picture, what can I expect to get in terms of my care? What's the state of the art, and can I expect it to be delivered in my home community? So I think if people would comment on that at all.
Could I just say, I would probably say evolving state of the art, because I think we have to continue to evaluate the impact of what we're doing. I think we see progress, but I think it's evolving. We've got to have people training as members of team and not in isolation if they're going to work as members of team. So I think it's evolving, but I agree.
So when we talk about members of team, this is interesting because I was just having an email exchange during a break with someone who works primarily on the substance use side of the world. And we've been talking about a behavioral health degree. One of the things we hear from primary care, we're involved in some projects around primary care and mental health and substance use disorder integration, is that primary care physicians often don't have backup, they feel. There's a specialty delivery system supposedly out there, or services, but they really don't have much access. And they often don't know whether it's a mental health issue or it's a substance use disorder issue. And is it time to think about behavioral health, or does that do a disservice to substance use disorders and a disservice to mental illness?
I don't think it does a disservice. I think that this goes back to the workforce issue. I mean, the way the workforce has grown up in those two fields, if you think of them as two fields, and it's probably a whole lot more than two fields. It's probably a collection of fields, and those of you who are trained in those could comment on that. But I think it's more that the history has grown up differently, and so the way people came into training or came into delivery in the substance abuse field in many cases was different than they came in the mental health field. And I think there's a lot to learn from the way those two fields, or those two different kinds of, often different kinds of provider systems or practitioner setups. I think there's a lot to learn from them. this whole issue of credentialing and how you train or how you create a new person who is then credentialed to do X is going to be a huge issue for the next 50 years. It's a big issue for the next 2 years, but it's a huge issue, I think, literally for the next 50 years because of the workforce that's coming along now. Many of us not that far from retiring out, and where does that leave us in terms of where we go forward? And then, frankly, it's so state-driven by how you get credentialed in particular areas, and the ACA is going to change that in an amazing way. The more it's an insurance-based reimbursement, the more the credentialing of that is going to be driven in many ways by the payer.
The distinctions are largely artificial. There's really no sort of scientific or strong clinical basis to distinguish intellectual disabilities, mental illness, and substance use disorders. If Nora Volkow were here, she would say that this needs to be an integral part of the curricula for the mental health professionals that are trained, because these are disturbances that affect the brain, they affect behavior, and they're very sort of co-associated, comorbid with each other. The incidence of mental illness, from psychosis to mood disorders in people with intellectual disabilities, is very high. The intellectual functioning of individuals with severe mental illness is also diminished as a population, and substance abuse is excessively comorbid. So these are largely artificial distinctions that are sort of culture, discipline, sort of government agency bound.
We're going to open this up to the audience in just a minute, but I have a final question for you, Senator Smith, to go back to the issue certainly of suicide prevention.
Yeah.
I don't know how much you've been thinking about substance use disorders and suicide, and if that's something that you're beginning to tackle, or you have some thoughts to share with us as we think about the work ahead.
Well, in my role as the private sector chair of the Action Alliance for Suicide Prevention, this is an organization established by Secretary Sebelius and Secretary Gates, formerly of the Defense Department. And our goal is to reduce suicide by 20,000 incidents over 5 years. And it brings together all these particularly vulnerable populations, specifically Indian tribes, gay and lesbian groups, young people generally, the list goes on and on. And we have found all these strings out there to pull together as part of our effort with SAMHSA. And when I think of my own son's experience, as the doctors just said, the notion that you can separate substance abuse from mental illness is a chimerical notion in my view, because many people who have a predisposition to depression, for example, are drawn to substances like a moth to the flame. And so they really have to be captured in one and the same, both at the training level, the treatment level, and ultimately the resolution to get them to a different place. So I don't think you can separate them, and we've certainly found that in our discussions and debates internally in the Action Alliance, that those are two strands that need to be pulled together. And SAMHSA just does a spectacular job at this. I'm so thankful for Pam and her great organization and the support she gets from Kathleen Sebelius. One of my big hopes in the Affordable Care Act is that when you get the federal government providing the standards, providing the leadership, providing the funding, ultimately a lot of this stuff will start pulling these strands together. And SAMHSA's hand in glove with us in trying to promote and push this. And eventually, it is the law of the land. It will get the funding, and it will create an environment in medicine whereby you no longer separate physical manifestations from mental manifestations of various kinds of illness. And we will have made a huge step forward as a nation.
Thank you. Questions from the audience? And I hope there's someone out there who can actually see, and we have some lights, okay. So we have a question over there and a question over here. And we have someone running around with microphones, 2 people, okay?
So, great panel.
Dr.
I have a question, and I want to talk about unintended consequences. So, Dr. Satcher mentioned that.
Could you start over? I missed the first part.
Sure, yeah, okay. I said I want to talk about unintended consequences of how we characterize mental illness, behavioral health conditions. And Dr. Satcher mentioned the importance of environment, and that one of the things we ought to be looking at is how do we create healthy environments, because we know that that can have an impact on people's mental health status. When we characterize mental illness, behavioral health conditions as a brain disorder, I get why we're doing that, because for the public that legitimizes it in some way, and I think it helps the public to understand that this is a health condition. So I get that, I understand that. But I also know that many of the behavioral health conditions that we deal with are also socially determined. And when we talk about it only as a brain disorder, we cut off our ability to think about other ways of intervening, other ways of helping people. And so I want to raise that to the panel, because I think we can put ourselves in a box that we frankly have been trying to get out of for the last several years, particularly as we move to more of a recovery orientation and how we think about what our treatment goals are. And so I'm just wondering if you could talk about the whole language, how we frame things, and are we putting ourselves in a box that will ultimately cut off our effectiveness as a field?
You know, I could say something if you want. It's easy to get caught up in the terminology, but I think that's really a red herring. It's misleading. If you have a pulmonary condition, you may need to relocate to an area that has a drier climate or has less pollution or things of this sort. Clearly, there are illnesses which are, by the most conservative scientific criteria, brain disorders: Alzheimer's disease, autism, schizophrenia, bipolar disorder. There's other conditions that one might consider more in the psychological realm, which is precipitated by environmental stress, poverty. Look at PTSD. PTSD is the only diagnosis in the 160 diagnoses of the DSM where there's a known cause. It's basically you have people that are exposed to some type of intensive stress, and it has an effect on them which becomes enduring and disturbing and disabling them. Is that a brain disease? It's environmentally caused, but it has nothing to do with any known sort of physical malady. So it's easy to get caught up in the terminology, and I agree that that has significance, but one shouldn't preclude the other. What I think we're trying to do is to facilitate the mental health, as Dr. Satcher said, whether it comes from some genetically induced brain disorder or some type of environmental effect that causes some type of psychological and emotional disturbance, which is distressing and impairing for an individual.
Yeah, and I'd be hard pressed not to believe that the mediator of that environmental stress is the brain. I believe that people coming back from Iraq and Afghanistan have, suffered these explosives. They were not severe enough that they physically maybe damaged the brain, but I think there's a lot of evidence that PTSD is 3 times as common in that population as in the rest of the population, and they have been exposed to these explosives, the IEDs, I guess we call them. But I want to talk about another unintended consequence. Because I'm concerned that we have taken the brain for granted. We've taken it for granted, and we work up patients, and we often ignore the brain. That's been a real problem. In most of our sports, it's okay to target the brain. Boxing, for example, football, even cheerleading. We allow for this brain to be a subject of damage. And 200,000 high school students last year suffered concussions playing football. So we've got to get to the point where we view the brain differently, give it the respect that it deserves. Because we have been ignoring it, we've been separating it from the rest of the body, and I think we're paying a price for it. I understand what you were saying, But I think the other way to think about it is, when are we going to take the brain more seriously, including its development? SAMHSA has helped us with the project that we call Smart and Secure Children. But the idea is we start with conception and work with parents in a community that's 80% single parents. And we work with those parents around how do you enrich a child's experience from conception to the age of 5. And it's really interesting. Number one, what happens to the parents when they come together? We just graduated 72, we graduated 90-something last year. But what happens is that they feel so much better about themselves as parents. So one of the things we've observed recently is that depression goes down in those parents when they come together and learn together about how to be better parents from 0 to 5. We've been measuring, what does it do to childhood obesity? What does it do to behavior and learning in these children? And obviously some of that we won't know for a while, totally. But I found it interesting that it affects depression in the parents, which tells me that in itself is going to benefit the child.
And of course, untreated depression in moms affects children.
Most definitely.
And most likely to have serious emotional disturbance, there is a real correlation. But you're talking about a program similar to the Nurse-Family Partnership,
Oh, that's right.
which also has wonderful outcomes, right?
Yep.
Everywhere from financial outcomes
Yep.
to the health of the parent to the economic success of the child. So isn't that really the prevention that cuts across, whether it's substance use or mental illness or any other social issue?
Well, it's interesting because you remember after Columbine, the nation was up in arms, and it was the only Surgeon General's report that I did that was requested by both the President and the Congress, because the nation was up in arms. So we did a report on youth violence prevention, funded by the CDC and SAMHSA. But the interesting thing was that this was one of the studies that we talked about in that report that obviously made a difference in violence in young people. But we haven't followed through because we wait until the alarm dies down, and then we do nothing. And so I think that's what we're.
Linda, real quickly, I know
Yeah.
you've obviously touched a nerve.
Yeah.
Arthur, the brain, I think, is something we don't know very much about. I mean, you've made that very clear, and I think Patrick's effort at trying to get us to do more about the brain is important. The elasticity of the brain, what affects it and what it affects, I think we don't know. I've also been reluctant about the brain disorder, but I am very clear now. Nora Volkow gets credit for that, that we can talk about the brain, and it gets credit in the sense of teaching me about that. We can talk about the brain in different ways without making it problematic in the way that you indicate. And Howard Goldman, who I also want to give credit to, said something a long time ago when I was in a meeting with him that I've never forgotten, which is, as conditions become to be understood as physical health conditions or conditions that we can explain in the body, they aren't mental health issues anymore. So for example, Tourette's syndrome. There was a time when people thought that was somehow mental health. I can remember early in my career when I was going into state hospitals and working with people there, people with epilepsy, people with other kinds of seizure disorders were in there, considered to be mentally ill. And we don't think of epilepsy as mental illness anymore. So as we learn more about the brain, or as we learn more about these conditions, I'm not suggesting that every single one of them will only ever be a physical condition, because quite frankly, things like diabetes, which we know is a physical condition, but we also know that there are ways that we can mitigate that or prevent it through behaviors. So there's, I think these things are intertwined in ways that we can't separate out as that's over there and that's over here, if that made sense.
We had another question over there, and then over here, and we.
My name is Valerie Poor. I run the TARA, National Association for Personality Disorder, which concentrates on borderline personality disorder. And since we began this wonderful conference with Brandon Marshall talking about borderline personality disorder, which was totally shocking to me that in public somebody got up and talked about it, I thought maybe I could sum up a little bit by bringing it up again. There are three things. You have standards, you have the brain, and you have suicide. So nobody in the borderline field that treats patients knows anything about the brain. And parents are very angry with their children because they don't understand them. So our organization does an intensive psychoeducation program with families, and the first thing we do is teach them all about the brain immediately.
Do you have a question for the
Yes,
panel?
I do. I want to know.
Please, because we
Yes,
want to fit in another
I do.
question. or
Like Brandon, he had 8 minutes. Okay, I'll try to do it in 2 or 3. In suicide, you have 2 different kinds of suicide. You have depressive people and you have borderlines, and it's 2 different processes. And I want to know why there's no standards of treating people on helplines and in treatment. You have a list on the SAMHSA website of evidence-based treatments. Doesn't anybody look at it? They don't seem
That's
to
the
use
question.
it.
Oh,
The
sorry, I
question
didn't hear
is,
the
what are you going to do about getting standards in so that people can get treatment? And how do you start differentiating suicide from depression to borderline so you don't knee-jerk 911 and stigmatize the patient and do them harm?
Okay, thank
2
you.
questions.
Anybody?
The issue of standards is a really different question than your second question, I think. And just again, real quickly, SAMHSA is working on something called the National Behavioral Health Quality Framework. It is a long way from being what we might think of as national standards for something. On the other hand, for the first time, we are trying to provide some leadership in saying, what are the minimal measures we would do for programs, practitioners, and payers to say this is a quality program or it isn't? It's meeting some basic level of quality. So that's only to say, we could have a whole conversation just about that. It's only to say that there's a lot of room, and it may be one of those things that's on the 50-year time frame to do around quality and standards and quality measures in our field.
Okay, next question. Let's see the gentleman back there.
Thank you. Hi, my name is Gary Lieberstein. I'm here with my wife Patty from Napa, California. We're here primarily as parent advocates. Our son was diagnosed with schizophrenia at 19 and ultimately had fixed delusions, voices. We lost him to suicide at the end of March of this year. I'm also a public official in my county. I've been elected prosecutor for 15 years, so like Secretary Sabellis, I knew all the people to talk to. We had everyone we could reach out, doing everything we could. We even had our son signing disclosures so that we could learn what was going on, and we couldn't do enough. And I think that someone touched the chord earlier about the difference between 17 and 19-year-olds. And early intervention prevention is a huge key, obviously. And our son in 3rd grade we were told he had a learning functional disorder. And we took him 3 days a week, and he did the over and up and down and all this, but no one ever thought for a second that that was any kind of precursor for mental disease. Once a child turns 18, as we all know, we lose the ability to help them if they don't want to help themselves. And when we also heard about, the public is scared, Sandy Hook and Aurora and everything, and there's a lot of people who need help wandering around, who aren't asking for help or don't have parents advocating for them. So my ultimate question is, what can we do as a society, and what dialogue can we have that somehow in an age of HIPAA and everything else, when a child turns 18, and when we know that most diagnoses don't happen until 19 or even 24, and the brain is still developing in that time, how do we reach out? How do we change public opinion? How do we do something for that population over 18 that we know some are ticking time bombs, many of them are hurting, and they could hurt themselves or others?
So what comes to mind, I think, if I'm understanding this correctly, and I'd love people more expert than I to talk about it, are 2 things. One is the Robert Wood Johnson study that's just been completed that Bill McFarland led around early identification and intervention, and the cluster of services that their project showed worked, not dissimilar to the RAISE project that's still underway, funded by NIMH, which again is looking at first episode, the ages 17 to 19 to 21, and intervening again in a range of ways, including cognitive interventions as well as school supports. And I wonder if anyone else has some thoughts about some next really policy steps that might move us towards being able to take something that is going to have significant research behind it, also international research, and put it into practice in some way across this country.
Well, this is one of the low-hanging fruit. First, I'm very sorry for your loss. When I hear these, cases that occur, to young people and come to the most tragic ends, it's really just heartbreaking. But this really is actionable now and is actually in progress. The RWJ study is one. The NIMH has funded 2 RAISE studies, which is historically the full spectrum of services, psychosocial, pharmacologic, for schizophrenia-related disorders was reserved for people in chronic stages of the illness, and the funding streams were only available for that. Now we've learned that the best way to limit the illness and its consequences is to identify people as early as possible and provide them with a multi-element, team-based approach, which nurses them back to stabilization from symptoms and then supports them into recovery and then retains engagement as opposed to cutting them loose. And this is already being adopted in the context of demonstration projects in various states. New York has set up 4 programs. California is buying into it. SAMHSA is seriously considering funding this.
And
CSS.
parity can be used to cover this.
But
so that's another way we can move, really, using the new supports that we have.
The social issue, though, that I think you're raising, though, is what do you do with an individual that does not have insight or awareness and doesn't want treatment?
This is an important policy age group. So the 16 to 25-year-olds is a focus for the president's Now is the Time plan. You will be very interested to know, and I am not lobbying, I'm simply giving you facts. The Senate Finance Committee, when they did the markup of the president's 2014 budget, did not include the Healthy Transitions program. They said they couldn't really understand what we were trying to do and that nobody came and argued for it. So just so you know, there's some information there in terms of that age group, and I think the intent was to try to use some pilots, to use some of the RAISE learnings, get at some of the legal issues, try to get at some of that transition. There are some models for that transition group, but they are not by any means out there where they need to be, and we were proposing to do that.
So just to put a punctuation point out, this is something where the evidence is there.
Yep.
It's the political and social will that's lacking.
As a former member of the Senate Finance Committee, this is not the first time they missed something.
And of course, our phenomenal host and our leader, Patrick Kennedy, is going to have the last word, as well he should.
Well, thank you all very much. And I find listening to each of these panelists, I was telling my brother, it usually takes me 20 minutes to say what they said in 10 seconds. So their brains are thinking a lot more clearly on a lot of these things. I want to say to all of you, the energy from this conference has been fantastic. And the way that you closed it, Linda, with the policy part of this is what I want all of us to leave with. So all this great thinking from all these great leaders, we need to determine what are the policy priorities. And then what are the priorities amongst those priorities so that we all spend our time working on the things that are going to have the greatest leverage to improve the whole world of mental health. And there are big issues here that have major cross-cutting effect across all of our communities: intellectual disabilities, substance use disorders, and people with mental illness. So this has been really exciting. I hope all of you know that we're going to continue to stay engaged with all of you to try to help act as a convener and a collator of all of these proposals in a way that can give some definition. Because at the end of the day, as Senator Smith can tell you, what all we want is just give me the plan. You know, tell me how to vote. I care about this. What do I need to do? And we need to basically, synthesize all this great policy into proposals, as Pam just talked about, so that when people like Gary care about it, they know where to advocate and they know what to push for. And then we have to think about what all of us can push for that's in our common interest. And so I will echo my earlier admonition that we need to be about oversight of how parity gets implemented. Because the real test of whether we call it brain behavior or mental health is, where is the money?
Show me
Where's the money? And the only way we're going to get the money is if we can hold people accountable to what works. And that's why we need the Leadership Forum, and Surgeon General Satcher tell us what works, so that we know what we need to pay for. But then we need to hold people accountable against what works. And with healthcare reform and these ACOs, they know very well that paying for those non-medical services can reduce medical costs, as we heard from all these panelists. So this is just a process in trying to get our message down and organize it, because there's so many smart people here, but they need to kind of dumb it down for those of us in Congress so that we can know what to do. I just want to say thank you to this panel. Thank you to all of you. And I want to, again, say so many people were instrumental in pulling this together. Keith Lowy in the back, Kate Borgers, Bill Emmett, Raffinelli, Julia Hoffman, who you've all heard from because she helped make sure we could pay for this. I thank her for that. And none the least of which is my wife, Amy, who permitted me to do this. And I want to thank my sister-in-law and my brother for being here throughout. And again, all of you, let's take this energy and let's keep moving forward. Thank you very, very much.